So I'll just take a minute and introduce myself. I'm Eileen Twiggs. I'm an attorney, and I've worked in healthcare for a number of years. I'm a friend of GovLab, and Beth asked me to jump on the phone with you all to talk about some of the HIPAA questions that you may have that are coming up in connection with the projects that you're doing. So I'm just here to have that conversation. So I think what might makes the most sense is to just let the teams fire away. I know one team sent me a deck, which I apologize, I did not have time to look at in advance of this call, and a couple of questions. So maybe we should just start there.
Hello.
Hi, Beth.
Hi. Okay, good. Have we started yet? I'm sorry. I hope I'm not interrupting. I'm having trouble dialing in.
We just started.
Okay. Sorry. Well, welcome and thank you to Eileen. I'm sorry that I have to join you by voice instead of by video because of where I am. But if I can be useful, please don't hesitate to let me try to be useful to help the traffic cop. But otherwise, I think, have we already set an agenda for the meeting? Otherwise, I think it would be very useful to have the teams introduce themselves and to quickly just have the three teams who are on deck essentially give a two-line summary.
Sounds good.
Did you want Norris to go first? Is that what you said, Eileen?
Sure.
Okay. I am the person that sent you the deck. It's okay, you didn't read it. I sent you some questions, and that was from a person who is not able to join us today. But really, where we're stuck is just trying to share the mental health data with. We'd like to share it with the law enforcement officer on the street. And we've been struggling to get one universal consent form, to get all the agencies on board with the form. And we haven't even been able to create the form because everybody can't agree. They all have their own consent forms.
Okay, so can we just take maybe like 3 or 4 steps back and just give me a window into the larger project, what the goal is, and so that I understand why you want to share the mental health information with the officer on the street?
Okay, Lucas County here in Ohio has been working on a project to reduce jail population. Mm-hmm. As part of that, we are looking at a deflection program where if we can find people with drug addiction or mental health, and currently now we're only focusing on the mental health, we would deflect these people into services instead of arresting them, because the real issue is their mental health. Mm-hmm. We're just trying to break the cycle. So we had taken this on as the project for GovLab to try to help. We have integrated data here in Lucas County. That is not the issue. We have the court, jail, and police data all integrated in databases that we can give integrated reports, provide data on the street. Mm-hmm. So the real issue is how do we share the mental health data with the officer?
Okay. And the idea is then, like, the cop on the beat would actually know better than to put the cuffs on. He would then refer the person for services or something. Is that the idea?
It's sort of a twofold goal. We have several studies that show that our most frequent utilizers of the jail also have mental health issues. And we understand and recognize the fact that the jail is not the appropriate place for individuals that the underlying issue is mental health and not criminogenic behaviors. And so to sort of divert those individuals from the jail, the officers on the street need to know if there's an issue with this person so they can provide the appropriate response, which would be into jail. And this issue is sort of perpetuated now. We've implemented a new pretrial risk assessment tool that really takes into account your failure to appears, your past criminal behavior, which if you have a low-level offense, which by practice in the past they would have been released from jail, now that we're looking at past behavior to predict future appearances at court, the lower risk offenders that have failure to appears that have multiple issues tend to score higher on this tool. So now we're keeping those people in jail instead of even releasing them. So it's kind of everything is sort of tied up together. We're really looking at revamping our criminal justice system. We're looking at implementing a 22% reduction in our jail population by September. And this mental health population probably comprises 66% of our individuals that are in jail.
Okay. One last question for you, and then when I think maybe one last, it depends on your answer. There might be another, who knows. And then what I think we're going to do is just talk to the other two teachers, because I just want to figure out if there's overlap between the questions that are being asked before we dive in. So where's the mental health data coming from? Who's actually, like, what's the source?
There's at least one centralized source, but that's kind of a gray area. We have our Mental Health and Recovery Services Board information. However, Ohio just went through Medicaid expansion, and so the Mental Health and Recovery Services Board no longer is the centralized repository if individuals are receiving mental health services through Medicaid reimbursements. So with that in the context, this has been kind of an evolving discussion over the past 2 years. We may also have to pull in service providers or Jobs and Family Services who maintains that segment of the information.
So all government agencies?
Yes, in theory.
Government agencies that are covered entities under HIPAA?
Well, and that's where part of our challenge is. The Mental Health and Recovery Services Board, after we all went through a HIPAA training about a month ago, I was talking to their HIPAA compliance officer, and she's not sure where they fall under this information because they're not actually a provider, but they have the billing records and they know who has access services or not. And so that issue is not 100% resolved yet, and we need to keep sort of working through these discussions to make sure everyone knows what they are and what they aren't.
Awesome. So it's all as clear as mud. That's the way.
Yes, and that's part of our frustration and part of our challenge right now.
Yeah, sure, of course.
Especially when it's as clear as mud, the HIPAA compliance officer is definitely on the more conservative side because, I mean, it's her job. But I've learned just going into this, I thought she would be a lot more resistant to discussions, but she's very open to discussions. We just need to figure out what their role is under HIPAA to make sure that they're not doing something wrong.
Around whether or not information, once it's been released to law enforcement, is confidential under HIPAA, right? And there were a couple of follow-on questions to that. Okay, so I'm just going to table that for 1 second and just ask the other two teams to jump in and just give a 2-minute overview of their projects and what their questions might be, and then maybe we can have
to post their questions if they want to not forget them or make sure that you see them also.
Hello, this is Montgomery again. This is the High Utilizer Early Warning System team. Can everybody hear us?
Yes.
Okay. What we're working on is, I guess in some ways maybe a little similar, but we're trying to create a system that will create a more complete picture of a mental health consumer, because we have people in law enforcement in the jails, and we have people we work with in emergency rooms at the hospitals, and they know that they're all interacting with the same people, but they're not getting the full picture, and they're not being able to really do their jobs properly. They can't really fully treat or care for the people they're put in charge of because they don't know everything they need to know about that person. So as a first step towards that, we're trying to create a system that would enable sharing, data sharing information about individuals, but at the same time, that information then could help us identify what are the indicators that make someone a high utilizer of ERs and jail services, so that if we start to see patterns, then we can say, oh, well, if this person has been in jail 4 times in 6 months and has been in the ER 3 times, this person is much more likely to keep using these services. And so that then, like a flag or something could show up on a person's record. So if that person then goes back to jail, there might be an icon that pops up, warning, this person is at risk for being a high utilizer. This is the time to intervene and introduce some other services for that person. We have great support from all the players. They all know each other. They work well together. They like each other. They really want this to work. The challenge, though, is getting the data in the first place. On the jail side, especially, the city jail, a lot of based. It's not electronic, and both the city and county jail, they don't track things the same way, and they don't do it even within their own departments. They don't do it consistently. Figure out how we can make it more consistent so we can get some type of baseline or something usable out of it. On the other side, the hospitals do have good data, but they're obviously, that's why we're interested on this call today. With HIPAA violations, they feel limited in what they could share. The hospitals do have some agreements with the mental health authority because they have patients that they both interact with. But as of right now, there is no way for the hospitals to share what they know with the jails.
Okay. All right.
Yeah. So we want to know basically what, the HIPAA requirements around that would be.
Okay. All right. And who's our third project?
Is Mary on the call from Adult Redeploy? I'm not sure if she's here. Looks like Mary, are you there? But looks like she hasn't joined us.
So we only have 2 teams then, with very similar type
Mary,
projects.
which team is that? Because maybe somebody else from the team is here.
Adult Redeploy?
Okay, so I think we should just go ahead, right? And then at the end, there may be other people with other questions who want to chime in. I see we have other jurisdictions on the line too, but I think if we can start to tackle what's in front of us, that would be great.
All right, so I feel like I have to
standing on one foot in 30 seconds or less.
I'm gonna disclose at the outset that what you guys are doing is fairly complicated from a HIPAA and other confidentiality law perspective. And so I just want to set some expectations there as to how far we'll get on this call. So just a couple of high level, I think, observations. So first of all, it is actually incredibly important to understand at the outset in any kind of a data sharing arrangement like this, who the covered entities are, because they're the ones who actually have the obligations under HIPAA. And also, just when you thought it was only about HIPAA, what other state laws are applicable? Because we have a number of other agencies at play, it sounds like, in here that may or may not have HIPAA covered entity status, yet may be subject to a host of requirements around what they can and cannot do with health information and other right now. Are you on mute? There we go. Okay. So that's kind of just a broad overview. The question that I got was whether or not protected health information is, I could just look at it actually. Let me just look at the question. Covered entity, for example, a criminal justice agency, that information is no longer covered by the privacy rule. So I'd like to say there's a yes or no answer to that question, but the sort of question is really, it depends. So first of all, folks should know that HIPAA permits covered entities to release protected health information to law enforcement and other public agencies for a very specific set of purposes, which I don't have off the top of my head, but they're things like you get a subpoena, or there's a public health emergency or a public safety emergency, things like this. There's a whole host of reasons that you can release protected health information to certain kinds of public agencies. It's a permissible release. It's not required. So that's just the other thing too. Most covered entities will make their own decisions about the circumstances under which they will actually allow the release of that information, even though it's permissible under HIPAA. It's not required under HIPAA. So that's just something to understand at the outset. Mental health information is more limited. And I'm sorry to say, I'm not an expert on the mental health portion of HIPAA, but my recollection is that anything that constitutes psychotherapy notes, which is not as restrictive as it might sound, it's really mental health observations taken in the context of a provider-patient relationship, that's very restricted. My recollection is that you are required to have the patient's consent, and that the exceptions to that are fairly narrow. And I don't know off the top of my head what they are, so I apologize for that. But so when you're talking about mental health data, you're talking about a very restricted set of information. But what we're talking about here, I'm sort of giving you guys this sort of as like broad stroke stuff. I don't think that what is being planned on either of these projects even would be permissible under HIPAA in the sense that it's not like there's no subpoena. This is more a wholesale exchange of information, right? Across the board. It's not like specific to an individual, but basically what we're talking about is opening up databases in a way that healthcare providers and law enforcement officials, and maybe some others, can have a window into a population and use it as they need it. Is that sort of correct?
Yes, I mean, really all we want to do is be able to flag a person as receiving mental health services
Yep.
in the last 2 years.
That in and of itself is
There are other jurisdictions that are already doing this.
mm-hmm.
Their HIPAA officers have given them the go-ahead. I believe Houston has something in place. I believe oh, what was I think Seattle has something in place where they share this information. And so we know it can be done within the context of HIPAA. It's just getting the mechanism to be able to do it and to be in compliance with the law.
Yeah, I mean, so that's sort of where I was going, which is like, I don't necessarily think that the provisions in HIPAA that are related to permissible disclosures to law enforcement are what's relevant here. I actually feel like what might be relevant here is something more along the lines of healthcare operations. So you know about HIPAA allows certain uses of information for treatment, payment, and healthcare operations. And healthcare operations are things that are designed to improve the quality of care. And so without knowing what's happening in Texas or Washington, it's a little hard to understand how they're doing it. But they're, you know, it sounds here like the primary users are going to be law enforcement as opposed to, at least in one of the projects, law enforcement as opposed to healthcare providers. And so I'm just wondering, like, is there a way to change the lens on that a little bit? And then I guess, if you know of the other projects that are doing this, have you spoken to them?
Yes, I have, and
okay.
they have been couching it in the continuum of care exception, at least for sharing of this information
to
jails. I am not sure I have the contact information for the Houston group that I just need to follow up on.
Yeah.
Unfortunately, this isn't the only project I'm involved in right now, so I haven't had time to do that. But I know every time we discuss this issue, everyone falls under the continuum of care, because that's what we're really trying to do. We're trying to provide the best level of care for these individuals that law enforcement officers may encounter, so we get them the help they need instead of putting them behind bars.
Right. No, I totally get it. And somebody just jumped into the chat, said something about the White House is working with HHS and plans to include HIPAA guidance in the toolkit that's forthcoming.
Yes, we're involved in that project as well.
Okay. So, yeah, I mean, my guess is that the folks who are doing this are doing it under the umbrella of healthcare operations, which is a pretty broad umbrella for use of healthcare information. Off the top of my head, without understanding the specific facts in detail, I couldn't say, you know, whether what they're doing in Washington or Texas is like, you know, sort of completely within the scope of healthcare information. So I think where you run into some potential issues here is just sort of thinking off the top of my head. Like, it's one thing for healthcare. That's the other piece of this too. If you're talking about a jail that has some sort of a healthcare component to so that's two HIPAA providers sharing information between providers for the purpose of coordinating the care of a patient. What's being described here sounds slightly different to me. And I just, you know, with the, like, using it for the purpose of giving law enforcement a window into where to properly direct someone, whether or not they become, you know, part of the jail population or part of a patient population. And so where have you guys, I guess, where have you gotten to then in the conversations that you're having?
at trying to make something work. We had a list of individuals that we considered our frequent flyers with mental health issues. We provided the Mental Health and Recovery Services Board a year's worth of information. They highlighted, and it was, I forget how many visits to the jail they had, but they were able to give us a subset back that of those individuals that were involved in the mental health system at one point, and we had targeted them for a project called FLIP. So in one of our data sets, we had a FLIP flag. So what this FLIP flag showed you was that this person is a frequent flyer who had some contact with the mental health system in the past 2 years. However, once we implemented it, the HIPAA officer at the board said, no, we can't do that. That's a HIPAA violation. And so that was our last attempt, and it was kind of a frustrating experience when you have a project driven by the Mental Health and Recovery Services Board that you do work on and you implement, and then you're told by their HIPAA compliance officer, who you would think would have been vetting this project as you go, saying, no, you can't do that. And so everyone really liked this concept. Everyone has really embraced this concept. And now we can no longer use that. So we're looking for some mechanisms similar to that we're able to utilize. And we're not there yet, and we know other places have it, so we know there has to be a way to do it. And so right now we're just kind of in the fact-finding mission of, can we make it work here given our state of Ohio laws, federal laws, and is it even possible?
Yeah, I think those are all the right questions. You know, but it's just not simple when mental health data is involved. Yeah,
and we understand it's not simple, but if we don't try to explore it, and we're better off than we were 5 years ago, and it really stymies some of the reforms we want to put in place because you're not able to meet the needs of these individuals, and just having the revolving door at the jail, at the point of arrest, at the point of contact, we're not getting anywhere. And if we have, based on fiscal constraints in our community, we're facing 22% reduction in our jail population, and if we don't figure out a way to identify individuals, public safety. So the only way we can implement reforms is to create programs, policies, and practices that meet the needs of the community. And so it's just, we're at just the exploration phase. We know ultimately in our dream world where we'd like to be. We acknowledge that we may not get there, but we have to try.
Yeah, of course. I'm just like I'm actually looking really quickly to see if I can find some, I mean, because one of the things that you just talked about is public safety, right? Which is
an exception to HIPAA, but it's very,
but I don't know if it's applicable to mental health data.
Well, I mean, the law enforcement exceptions, like you said, are extremely narrow and is subject to request. I know in Charleston, their way of notifying law enforcement is to have a team of mental health professionals dispatched with law enforcement in a possible scenario where it may be a mentally ill person involved. And so it's the mental health worker accessing the information, but they're able to share that information with the officer on the scene. And then they also have a separate unit that then handles the separate requests.
Knowing that you do want to take the extra mile, or you're going to the extra mile to, of course, have the data being shared in a manner that is fully protected according to the statutes that you need to embed. But again, feedback mechanisms
it's just very
are quite often ignored, so that you actually have a mechanism for complaint or red flag issues, and then ultimately being transparent about the challenges or the risks embedded in certain data, especially if you're dealing that, if you share it with other organizations who will use it for other purposes.
Yeah. So
I don't know whether that gives you an answer.
I mean, I think one of the things to explore is there a way?
Okay, I have a question. This is Angela from Dakota County in Minnesota. And I'm wondering if you could talk a little bit more about the data invisibles term. I've never heard that term before, and I'm wondering if you could give a couple of examples.
Actionable pieces of this are on the healthcare side,
right? Well, so
law enforcement side, and then maybe.
So the term, let me think. The term really tries to
healthcare operations.
Go about the potential bias you might have.
I think talking to the people who are
by using a universe or a sample to do, for instance, performance or do prediction that is incomplete with regard to certain kinds of groups in society.
No, I get it.
So that means that, for instance, you could say, well, look, we're going to use this data set. For instance, just to give you an example, which might not be, and again, when it is administrative data, then quite often you have less of that color. But for instance, if you would use call detail records,
and I was going to say, and sometimes like the
to make an assessment of, for instance, mobility
but the other thing is like to talk to
individuals
very specifically about what you're trying to do.
And then based upon that, you would then adjust the bus routes, for instance, right? I mean, this is obviously perhaps no criminal justice example, but to give you an example to get a sense what I mean, then you could have the complication that actually those who might use the bus most might not have a phone. And as a result, you would use phone data to actually make decisions that impacts them, and they were not part of the sample that informs you about mobility. And so the data invisibles in this case might have been those who don't have access to phones.
And this is, there's some things that concern me,
and they might be implicated in the decision because they might also be the ones that are using bus most. And so the data invisibles ultimately here have skewed your universe, and there is a bias with regard to the sample. Same thing for banking details. As you know, there's still a large group in society that don't have banking access to bank or financial, and if you start using, for instance, banking records as a sample, then those who don't have access to banks automatically
I just don't want, there's a stigma involved with this, which is the very reason why the protections are in place, and we're very cognizant of why HIPAA is there and why there are protections.
By this sample
we know
that your data set
similar information.
or the universe that your data set really
stigmatize
knows
someone
about,
because it's not.
What are the ones that are not included in your sample but will be implicated by decisions that are made based upon the universe that and the data sample that you are using? And so that's what I mean by data invisibles.
Covered entity to covered entity.
Is that you?
Yes, it is. Thank you. It's sort of the unintended consequence of who's being left out when you aren't working with that full set unless it's very transparent.
Probation information, but in Ohio, probation information is the most protected information in
what that
the
sample data
system.
set entails.
So unless the probation information is on the court record,
and again, it could be, for instance,
so we do
if you use with data, for instance, that is self-reported, then that might also be a challenge because not everyone is reporting, and then it might be a specific group that you're actually making decisions for, and they might not have been part of the self-reported universe, for instance.
Information sets, but we can't share it. It's protected under Ohio Revised Code. So, I mean, that's the downside of
this is Montgomery, Alabama team.
Justice
and we were wondering,
system
have you
you
ever
actually
taken
start
a
getting
team of
into
stakeholders through
more
this
of the
process?
treatment aspect
And
of
if you
things,
have, how long does
highly
it take to
protected
get
as well.
consensus
It's difficult to even
on data
share that
collection and
information
analysis and
between
review?
across courts.
Right, good question.
Adult records.
Well, in my previous life, I was based at the Mark Foundation, as Shemendra knows. And so one of the projects there is about developing
some of the courts are even hesitant to tell people if they're on probation or not unless it's on the public
agreements
record.
for medical records.
That court docket that
we
gets you
created
the
something
ability
called
to share
Connecting for
without worrying
Health,
about
which was
breaking
exactly
Ohio
this
law.
multi-stakeholder approach in order to develop what we call a common framework for health exchange.
To kind of think about
now,
is
it was a lengthy process,
is when
but at the same time, several products came out of it, which was at least a consensus about what were the data agreement policies that you've had beyond HIPAA, for instance. What was also came out of it was, for instance, the blue button, which enables, like what was mentioned on the clicking of button, you basically have access to certain kinds of data, and what are the policies around that. It was a lengthy process because it started from scratch.
Issues and gray areas, right? And so HIPAA is
the additional complexity was that it was a national
and there are a host
project,
of state laws on
so
top
there were
of it. And it sounds like
150
you guys
different
are really
stakeholders.
familiar
I can assume
this, but I
that
think,
if it's
my
smaller set of
other
stakeholders,
observation
will likely be quicker. But ultimately, I think it was very worthwhile
to make sure
because
that these
without having the buy-in,
are being held in a multidisciplinary way, and so not giving one person the veto, in a sense of
liquidity of the data that you wanted to have. Now,
I found,
I would be last one to say
in
that we need to do
working
more,
within the construct
but I
of
think
a
at least
healthcare
it
provider,
was a
that
necessary element.
when you get a bunch of people in a room, and you can structure things in a way that it is more adaptable to the letter of the law and addresses the same, sort of the same
coming
goals
back to the last question,
the way you were originally trying to do it.
The curation of who is involved
I feel like,
does matter. And so
and maybe you're doing this,
your
I don't
mapping
know,
and
but making
curating
sure
who you
that
want to have at
lawyer
the
is
table,
in the same, or the compliance person is in the same room with the people who are driving the initiative at the outset to really
as flawed, or
talk about solutions as opposed
inclusive.
to
curation
what you're trying to do is a good thing. I think everyone can agree on that. And so how do you
at each
sort of
stage,
work
whether there's a
within
different group
the
that's needed?
framework
It doesn't
of
always
HIPAA
have to
and
be
other
the same
privacy
group
regulations,
at
but
different
accomplish your
stages.
goals?
You could say we need to have a fully inclusive group in order to define the problem that we want to solve, and then we go smaller as we are developing solutions. And so it is important to at least think this through in order to ensure that it is seen as inclusive. But then you could get a mandate by an inclusive group and saying, okay, now we're going to go into working groups, which are smaller and more agile to a large extent.
Willing to have some of these discussions.
We don't know if you're raising your hand, so you should
so
just chime in. We don't have anyone in the queue waiting, so I want to see if anybody who's not on the computer but on the phone wants to ask a question or
discuss the
react.
sharing of data between systems with the intersection of behavioral health and criminal justice being the main focus.
This is Shemendra.
So I think,
thank you, Beth, for the opportunity. Stefan, I appreciate your comments. And yes, it's good to hear the reference back to the Markle Foundation and a lot of the real seminal work you did there and with many others as the basis for a lot of what we're doing here with the information sharing environment.
I don't know. Then maybe
I had a question and a comment,
having the background in HIPAA. I mean,
kind of
I'm
intertwined.
an attorney, but
What you just were describing about the more inclusive, governance structure than necking it down to specific subsets of folks working on problems. I tend to think about that as communities of interest, right? That potentially have lots of different specific sharing problems, but really need to define their security and privacy constraints and other constraints that sort of give identity to that community of interest. And then
they are definitely not
specific teams have a specific information sharing requirement, right? To be able to share
make the wholesale
data about an incident or a request for information or what have you.
You're going to need
Does
to
that
look at this
dichotomy
creatively
make
under
sense
the
to you?
framework of HIPAA, where
and clearly community of interest, community of concern,
and to see if there's a way,
ways forward.
Because all the time, like quality and risk
we can also be more innovative these days around actually how you develop those communities. So it doesn't always have to be physical
constructs
community. Quite often, most of the time goes into actually organize the meetings. Quite often,
here I'm not sure
they can actually do a lot of work already in more exactly collaborative fashion by using actually some of the tools that we have today. Regard to how to do drafting, for instance, or how do you go about some ideation with regard to the solution, or how do you go about getting some legal analysis and comparison, for instance. All this can be done within communities of interest or within a specific kind of working groups and task forces that are specifically trying to address one key question.
Have signed consent to share personal information. Will our providers accept that consent
call for comments
and allow us to share or not? So that's kind of floating out there in the background as well, and it's just trying to figure out how to make all the pieces fit and how to make this work.
Then I'm going to say thank you very much to Stefan for the fabulous and thorough presentation. I assume it's okay. I've told everybody that we'd be happy to share the slides if that's okay with you.
Not just like in a one-off
via the listserv. We've already had questions from people who would like to see the slides, and as Stefan is,
I think it's going to be tricky, but I think I think there are ways to probably
questions
get it done.
about how anything that he's discussed
but it's going to
applies
require
to the
someone
specifics
to
of your
roll
own
up their
projects.
sleeves
Am
and
I correct that you're happy to
figure out how to accomplish?
Yeah, absolutely. And ultimately, this of course is a generic framework that needs to be made concrete in order to have more value.
The HHS
hopefully, it
website
allows
is
you to think this through as a process rather than just we need
I
a
don't want
policy
to
and
cut
then
this conversation off, but I also want to be mindful of time. And I noticed that other folks are jumping into chat. So I don't know if folks want to jump in and ask some questions.
Hughes, I think Hughes, do you want to go next and ask your question?
Yeah, go ahead.
Yeah, this is Jeff from Montgomery, Alabama. Eileen, one of the things that we're looking at is identifying at the front end of somebody going to jail, whether they have a mental illness, using an instrument that has 8 questions on it that's pretty well regarded in the field, and using that to figure out who's got a mental illness. And what we'd love to do is send a list of those people to the hospital's emergency rooms to see if they're the same folks who are using the emergency rooms. And I guess my question is is a screening tool for mental illness, are the results from a screening tool considered to be protected health information?
So let me just ask a couple of questions. Are you suggesting that the screening tool is going to be initiated on the provider side?
At the jail, right at intake, when somebody is brought to jail, as part of the information that's gathered when somebody's being booked.
Mm-hmm. So, and who's, sorry, so protected health information is, generally speaking, health information that is generated in the context of a provider-patient relationship. That's like an oversimplified example. So this sounds like it would definitely not, right?
No, there's definitely not a provider. It's just the staff at the jail would be asking the questions.
But what if it was the nurse the question?
But it's better than it isn't.
Yeah, I'm saying, but they'd have to make sure it wasn't, right? Because if it was one of the nurses that asked the questions, then it would be protected, right?
The nurse where? Well, it doesn't matter. She's a healthcare professional.
The jail. The jails have nurses.
Yeah. Is that a question for me? Do they?
I was just verifying that if it happened to be the nurse at the jail who used the screening tool, would it then be protected health information?
She's a healthcare provider, yes. Yeah.
But otherwise, it's not protected health information?
Well, if it's information collected in the context of law enforcement interaction, it wouldn't be, and there's no healthcare provider involved, then it shouldn't be, I don't see how it would be covered by HIPAA. It might be covered by something else, though.
Yeah, it might be.
And so I don't know who just sent this document out, but it looks like a pretty good resource. How the screening tool, so the screening tool isn't sharing any information from a provider to law enforcement. It's basically generating, for lack of a better word, a profile through some questions at the law enforcement side, right?
That's right.
That shouldn't trigger HIPAA. That should not trigger HIPAA. But again, I don't know if it'll trigger other things. And then what happens to that information? Where does it go?
What we're thinking, it's not being done yet, but we would like the jails to identify the people who are coming to jail, who are coming there often, and who have a mental illness. And this tool that I just talked about is the screening tool we'd use to identify the mental illness. And then compare that list. We'd like the emergency rooms to compare that list with the frequent flyers to the emergency rooms who have a behavioral health diagnosis, and see if they're the same people. And through that, identify the 5% of the people who are consuming 50% of the time of the jails and the emergency rooms.
Do you guys have a HIPAA savvy lawyer working on your team?
No.
Okay.
No.
Yeah, I mean, because I do think that's going to be a critical piece of this, because again, like, go back to some of the questions that I sort of flagged at the beginning, like it's really important to understand like who the covered entities are. And, to the extent that there are covered entities on both sides of this transaction, and there is an argument to be made that the information is being shared in connection with the treatment of a patient, right? So if that's, through a healthcare professional working under the, umbrella of the criminal justice system, to a healthcare professional working under the umbrella of a hospital or, a practice or a public health agency, like that's just a different set of considerations than the cop on the beat. So I feel like there's some foundational work that could be done on both of these projects that, to sort of maybe reframe them a little bit to think about, how the information can move as opposed to sort of its whole set of restrictions under HIPAA that would require just a bunch of research for me to, sort of get into that a little more for you guys. But I do think you both, it's always the data projects that dig up all the sort of, all the stuff that's buried and, in the legal world. So I think that would be my first sort of recommendation to both of you is, number one, like figure out like who's dealing with who here at a very specific level, and whether or not there are covered entities around the table that, you know, and I would, the lawyers are going to need to craft a solution that meets the goals as opposed to put up the roadblocks. Because HIPAA is restrictive, but it's also permissive. And so working within the permissive pieces, I think, is the direction you want to go in. And talking to as many people that you can find who are doing this and figuring out how they've done it. And don't always, you know, I would say don't always just accept at face value that they're doing it correctly, but it's more information to feed your own analysis. They very well may be doing it completely correctly, but they may also, you know, have interpreted HIPAA in a way that you guys aren't comfortable with.
That we have. And I also shared another, in addition to Sarah's resource, I shared another thing in the chat for those people on the phone. Maybe Anirudh, what we can do is to send Sarah's link and my link to the listserv, so that because people on the phone can't see what we've posted.
Yeah.
Okay, thanks. So, or Eileen, any parting words other than the ones you've offered, if there are no further questions? I'm going to mute myself again.
I think find a lawyer who's going to who's motivated to help you get what you're trying to do done. It may not get done in exactly the way you envision it at the outset, but like there are ways to move information under HIPAA, and you just want to take an approach that is mindful of that. You know, you want to manage the risk of what you're doing, but not take, you know, if you have an extremely conservative compliance officer, then you want a proactive lawyer on your team too, who believes in what you're trying to do, because you just, and maybe even, you know, start a little smaller. But really just be creative around who the parties are, how the information, you know, ideally how it would move, but like what are some peer-to-peer sharing in these kinds of projects is invaluable. And so finding out, even if it's not exactly sorry, I didn't have a...
Just as a quick coda to that before I thank you is build some tools to do exactly that, to further and scale this kind of peer-to-peer knowledge sharing beyond what we can do in a live program like this, is to create essentially a database of jurisdictions and who's doing what, so that it will become easier, we hope. For volunteering your time and for helping to get the conversation started. I hope that if people have questions or want to call upon you, I don't know, I will ask you offline rather than embarrass you on the spot, if we can figure out whether you or you know others who can be helpful to people, if there is a desire to find somebody with HIPAA expertise, we are happy to figure out how to support that kind of additional counseling in a more intensive way to help people move forward. So I want to thank you very much for sharing your knowledge and expertise, and to everybody for participating, and keep the questions coming. And we'll share a video. We'll share the recording of this chat as well as then the links that were shared in the chat afterwards, so that we can dive in. And please, as you're developing your learning further, by all means, we invite people to use the list to forward those requests to others, and then to forward them further on to friends of friends, and to see if we can't get some greater clarity. So thank you very much. And thank you, everybody.
Thanks, everybody.
Thank you.
Thank you. Bye.
Thank you.